Thank you very much, sir. It's an honor to be in this course. So I've been given a situation that a patient has post-cataract surgery refractive surprise of 4 diopter. So it can be either a +4 or -4, I assume. So we all know that an ounce of prevention is always better than a pound of cure. So in our cataract patient, we always have to be careful that what are those set of patients who may land up in post-operative refractive surprise. These patients are who are high hypermetrop, high myope, patients who have undergone post-RK, who have undergone PRK and LASIK patients, patients who have dry eyes, post-retectomized eyes, and post-keratoplasty patients. So in these patients, we always need to be careful that we use the appropriate IOL power calculation formulas to not land up in the refractive surprise like this. So we may get, instead of taking all the precautions, there are situations that we get a surprise of the plus or -4, what has the situation been given. So what all options we have in patients who has a surprise of so much ±4 diopters? There are 3 choices which we have. Either IOL exchange can be done, or piggyback IOL can be done, or cornea-based procedure like PRK or LASIK. So let's see. So if you are seeing, I think we should divide it into that whether this is an immediate post-operative period or a late post-operative period in which we see the patient, or whether we implanted a monofocal IOL and we got surprise, or it's a multifocal IOL and then we got a surprise. So if it's an immediate post-operative period, you see the patient on the next day. So these patients are, of course, your own patients. You see on the next day, you see that he has -4 or +4 diopter of refractive surprise. So for these patients, you need to go and check your preoperative data, that what are the axial length, K readings, and whatever has been fed in the IOL power calculations, and what formulas have been used. So see that where the mistake has happened. Then you also make sure that whether the right patient has got the right lens, whether you have by mistake put the lens of some other patient in this eye. So you need to go and check your data, that what is the problem in these kind of patients. Of course, in immediate post-operative period, if you have myopic surprise, say of -2 diopter or something like that, you should rule out the capsular block syndrome. That's the accumulation of the viscoelastic and all material behind the lens in the capsular bag, which can push the IOL forward and can lead to the myopia immediately. So that condition needs to be tackled with YAG capsulotomy. Once you do that YAG cap, lens pushes back, it goes in the place, and it settles down. So rule out that. And if you rule out that, you know that it's the lens which you have done by mistake or your calculation have been wrong. So go again, do your calculations again. And then the best thing is to do the IOL exchange. Whether you have implanted a monofocal lens or a multifocal lens, you need to go and do IOL exchange. That's the only way. But not in the patients who have already undergone, who are post-RK patients. Because in post-RK patients, the refraction many times need almost 2 to 3 months to settle down. So if patient is not a post-RK patient, it's a normal patient, you go and do IOL exchange. So one quick trick for doing IOL exchange I like to share here, that whenever you are exchanging the IOL, first you take the IOL out in the capsular bag in the anterior chamber. First you go and implant the IOL in the capsular bag. So now you have a IOL scaffold so that you don't rupture the posterior capsule while cutting the IOL which you are going to exchange. So once you put this IOL in the capsular bag, now you can go ahead and cut with your scissors. Hold this lens with the micro forceps from side port. And there are many ways to take out this IOL from the anterior chamber. Either you can bisect it completely as I'm doing here, make in 2 halves and take out, or you just give one large cut and by the hinge technique, you can take the whole IOL out with 2.8 millimeter incision itself. So now see, if we have a multifocal lens implanted and we have a surprise, and patient comes 2 to 4 weeks after surgery, it means this patient is either dissatisfied from some other doctor, or he is taking time. The doctor, no, I don't want to go for exchange, or if you are not comfortable for IOL exchange. So if the patient comes 2 to 4 after surgery, then there are two options you have. IOL exchange, in my view, is the best option for these patients, or piggyback can also be tried in these patients. We have Sulcoflex lenses available for piggybacking, or you can use a 3-piece IOL for piggyback. Or if the patient comes months after surgery, and if he has the diffraction error like this, for months after surgery in a multifocal IOL which has been implanted, I think piggyback lens is best, because after months of the surgery, there are capsular lenticular adhesions are there. It's very difficult to exchange the lens, and it's very demanding technically. So piggyback lens is the best option. Or if you have access to refractive machine, you can go ahead and do PRK or LASIK also. So if you have a monofocal lens patient, so you have all the options available. If he comes 2 to 4 weeks after surgery, you have IOL exchange, piggyback, or surface ablation can be done once you have 4 to 6 weeks passed off. And if patient come late after surgery, after 4 to 6 weeks, even you can do LASIK after 3 months. So for LASIK, you need to wait for at least 3 months, so that, yes. So just a quick word that who are the ideal candidate for piggyback IOL. Your IOL has to be intact in the capsular bag. Normal or deep anterior chamber has to be there, and the patient doesn't have any glaucoma or pigment dispersion. And this is a simple calculation of piggyback IOL. If there is a hyperopic error, you multiply the spherical equivalent by 1.5. If patient has +4 diopter of the surprise, you implant +6. And if he has myopic error, you multiply the spherical equivalent by 1.2. So this is a Sulcoflex lens design. So I think if we have a situation like this, everything is not lost, and we can rectify this situation. Thank you very much, sir.